Good morning, and welcome to today's discussion of the Seinfeld episode of the Diplomats Club. So to kick it off, any observations or any choice of where to start? Any particular scene, any particular character you'd like to discuss this morning? Anyone?
I guess we can start with Kramer. He was displaying some signs of gambling disorder in this episode as him and the Texan try to bet on which planes or like the flight times and takeoff times. So things you could see that he was demonstrating, he was chasing after, evening out as he kept losing. He needed a friend to come in and give him money when he didn't have any more to bet. We didn't see Kramer try to really quit, like it didn't get that far in the episode, but usually people with gambling disorders have difficulty stopping. And then, in general, Kramer's a pretty agitated person, but agitation and things like that.
Yeah, this condition, gambling disorder, was most recently categorized in the impulse control disorder chapter. So it was considered to be on a continuum with other illnesses like pyromania, as well as intermittent explosive disorder and others. In 2013, with the publication of the DSM-5, the APA moved it from the impulse control disorder chapter to the addictive disorder chapter. It's a new chapter in the DSM, new as of 2013. And it itself is divided into two sections. The substance-related disorders, alcohol, cannabis, etc., and the non-substance related disorders. And one example there is gambling disorder. If you looked at the definition, and it really hasn't changed from the DSM-4 to the DSM-5, there is significant overlap. Signs and symptoms that you will also see in conditions such as alcohol use disorder, cannabis use disorder, etc. So because of that, because of the accumulating evidence in the literature, the American Psychiatric Association did move gambling disorder to the addiction disorders chapter. Before we talk more about addictions, does anybody know the other condition also published in the non-substance related addictions disorder chapter?
Is it sex addiction?
Not yet. Now, it's often discussed, but the APA has not recognized that yet. Internet gaming disorder. And again, if you look at these conditions, internet gaming disorder, gambling disorder, and any substance-related disorder, the DSM criteria demonstrates significant overlap. So hence the addiction disorders chapter of the DSM. One of the things about Kramer as well is that his behavior, and here you're going to have to cheat because these are contained, that is, Kramer's behaviors are contained in other episodes, but he demonstrates addiction in other spheres, including caffeine, nicotine, and perhaps others. So even though controversial, there might be some cross addiction. And we see that in this as well. Kramer does seem to have multiple different personality traits that come to clinical attention, but one is how, quote unquote, addicted he can become to both substances, caffeine, tobacco, as well as non-substances, gambling. Treatment. Kramer comes to you for help with the behaviors that are identified in this episode of the Diplomats Club. What treatment plan are you putting together for him?
Probably first line would be cognitive behavioral therapy, and then referral to like a gambling anonymous group or something similar.
Yeah, I mean, that's first and foremost is looking at this biopsychosocially. The primary focus would be on psychosocial interventions. And that would include both individual therapy as well as group therapy. For example, Gamblers Anonymous. No FDA-approved medications for gambling disorder. Like any mental disorder, a comprehensive psychiatric evaluation may uncover a co-occurring mental disorder. So evaluation of and then treatment planning for co-occurring conditions is a routine aspect of psychiatric care. Any other thoughts on either gambling disorder or Kramer in this episode of the Diplomats Club? Okay, any other scenes or characters from last night's episode you care to discuss?
I thought it was funny with Elaine and the guy she was working for with the whole socks scene and how he was like freaking out that like some are too tight, but then like this one might fall like at the end of the day, but not yet. But like in the long run, like he's being like a little bit dramatic about his socks.
Right. So Mr. Pitt presents to you with, I'm not even sure what the chief complaint would be, but he presents to you because of his concern or because of his behavior linked to that scene, his socks. What are some of the things you want to discuss with him? What are some of the things that you may consider if both he and you believe that this behavior is resulting in clinically significant distress or impairment?
Like I would want to assess him for anxiety, probably.
Yeah, I think that's going to be a recurrent theme today. And we're going to carry this over to both film analyses this afternoon and probably reviewing the anxiety disorders. Mr. Pitt does certainly seem to be overly focused on his socks, and you could see some level of irritability in those scenes in his behavior. And to the extent that this is all deemed to be clinically significant and Mr. Pitt asks for help, I think anxiety would be a place to start. Now, one thing to keep in mind from a clinical perspective, not likely to appear on a shelf exam, is that anxiety in and of itself is not a disorder. And I don't think I need to really belabor this. Anxiety, especially for this group, can be very adaptive. So when those short coats go longer, your anxiety is going to increase. So I'll let you in on a little secret. And when you hold that code pager, your anxiety is going to increase even more, but to the benefit of everyone in that hospital while you're on call. On the other hand, if you didn't feel a thing, you're likely a very dangerous doctor, right? So anxiety is and can be very adaptive. So when somebody presents to you with what looks like an anxiety disorder, when Mr. Pitt presents to you, the question isn't necessarily why do you have anxiety? It's why is your anxiety maladaptive? And if you focus on that and focus on more positive adaptive outcomes, you're much more likely to help your patient than if you pathologized anxiety. Maladaptive anxiety sometimes constellates with different traits, hence why we have built these different anxiety disorders, right? And I think the tip of the iceberg here may be that Mr. Pitt is struggling with clinically significant obsessions. These are maladaptive thoughts, and therefore primary in the evaluation would be obsessive compulsive disorder or OCD. It's a place to start. Any other thoughts about Mr. Pitt? The other thing about this character, again, it's an alternative episode, is that he does get into, in the Thanksgiving parade episode, his relationship with his father. And it appears that very harsh and distant relationship impacts his current adult behavior significantly. So, and the reason why I bring that up is because, again, another clinical pearl that probably is not going to appear on your exam, and that is While I know that now, after this clerkship, the majority of you have switched careers and are going into psychiatry, those of you who are not have to remember that, number one, you are going to see anxiety disorders in your non-psychiatric ambulatory care clinics. You are going to have to address this issue. Number two, as a clinical pearl, the number of patients that you do not refer to therapy with a diagnosed anxiety disorder should always equal 0. There are just rare exceptions to this rule. So as a gold standard, everyone you meet with clinically significant anxiety for whom you make a diagnosis, psychotherapy should be part of a routine biopsychosocial treatment plan. And if you forget that, just remember Mr. Pitt. Thoughts, observations? Anything else going on with Elaine here?
I want to talk about how the lawyer of Mr. Pitt thinks that Elaine is trying to kill Mr. Pitt because she's in his will. And so she tells him to go to the pharmacist, and then he goes, and when he gets there, like Kramer already like knocked down like a side cap, I think it was. And so Jerry's like trying to pick it up, but he looks like he works there. So Mr. Pitt asks him for advice, and then Jerry just gives him whatever. And then it turns out that he gets like even more sick. So
there's a couple of things going on here. One is the observation and misinterpretation by the lawyer, and then maybe a similar misinterpretation of environmental stimuli by Mr. Pitt, identifying Jerry as working at that pharmacy. Now, I don't really believe either of these are ideas of reference. However, it certainly opens the door to discuss this type of pathology. The idea of reference is a type of delusion. The delusions, similar to obsessions, are maladaptive thoughts. They're deficits in thought content. The obsession is considered to be a milder form, where the delusion, the more severe form. The cutoff is reality testing. An individual who is delusional has a breach in reality testing and remains rigid in their belief, even when presented information to the contrary. On the other hand, the individual with an obsession may or may not be reality-based. However, during any discussion, during any observation of their behavior, their obsessive behavior, they do demonstrate or should demonstrate some level of insight. That insight is absent in the individual who is delusional. So that is the cutoff in what primarily differentiates the delusion, that evidence of psychosis, albeit a deficit in thought content, from another deficit in thought content, a milder form of deficit labeled the obsession. Okay, so we talked about perhaps Mr. Pitt being obsessed, demonstrating an obsession focused on his socks. On the other hand, we have his lawyer that makes this comment, and then we have Mr. Pitt a little later on also misinterpreting. Again, it's going to be, I think, a valid discussion, and we really would need to sit down and speak to both the lawyer and Mr. Pitt as to whether or not these are true delusions. But if they are, the type of delusion that I think both characters demonstrate is called the idea of reference. The idea of reference is that delusion that is a misinterpretation of a real environmental stimulus. The lawyer and what the lawyer observes actually happens, but he has a delusional misinterpretation of, in this case, Elaine's motive. Okay, similarly, Jerry was really there in that pharmacy. There's no mistaking that. However, there was a misinterpretation of that environmental stimulus, AKA Jerry, by Mr. Pitt. So while these may not be true ideas of reference because they may not be truly delusional, those two scenes do allow for the discussion of this particular form of delusion called the idea of reference. That is, a real stimulus in the environment is provided a delusional or psychotic misinterpretation. Right? ideas of reference. And the other thing I wanted to make, again, linking aspects of this particular episode, there is also a reference to the son of Sam in this episode. Anybody here hear of or know who the son of Sam is? The son of Sam, David Berkowitz, was a serial killer in New York State back in the mid to late 1970s. And in the summer of 77 or 78, there were multiple murders in New York State that, quite frankly, paralyzed an area and an area of our country. The son of Sam, David Berkowitz, was apprehended largely because of a tip, as a result of the son of Sam suffering from an idea of reference, and that after his capture, he was noted to have blamed the motive behind what he did on his neighbor's dog. Now, people, that is his neighbors, did report to the police that the neighbor's dog incessantly barked, right? It was an outside dog and it barked constantly. David Berkowitz interpreted that barking as orders to kill. So the idea of reference really is a core part of the understanding of what happened back in 1977, the summer of Sam, that is David Berkowitz's killing spree. Right, so again, I believe, and I have to look this up to be honest with you, I obviously haven't interviewed him myself. I believe David Berkowitz was diagnosed with schizophrenia. Idea of reference, psychosis, schizophrenia, again, that hallmark psychotic disorder, example of idea of reference. So that name appears in the script of the Diplomats Club, and we see signs of, or at least behavior related to, what could be the idea of reference in both Mr. Pitt as well as his lawyer. What happens in that pharmacy when Mr. Pitt mistakenly believes Jerry to be a pharmacist?
He buys appetite suppressant pills.
And what are those pills likely containing?
Roxine,
What class of medication?
like a thyroid medication, like a thyroid stimulant.
You stand. Mhm. And what would be the concern of? And let's switch gears a little bit here. Let's say somebody that you care for and have diagnosed with major depressive disorder, and who you have started an antidepressant, does the same exact thing. What would your concern as a prescriber be of someone being prescribed an antidepressant? Let's call it Nardil, which is a third line antidepressant in the monoamine oxidase inhibitor, or MAOI class. Buys the same exact medication over the counter. What is your concern?
Maybe like hypertensive crisis.
Yeah, right. We always tell our patients to please check with your pharmacist before buying anything over the counter because of potential drug-to-drug interactions. And there are a couple, well, there's more than a couple, but there are two drug-to-drug interactions I want to briefly review this morning. One is the result of an abrupt rise in blood pressure. And again, here we're talking about the abrupt rise when we have two medications with the same stimulant side effect, often referred to, let me just backtrack a little. The MAOI here with either pseudoephedrine or some other stimulant, thyroxine, and it could even be prescribed too, right? So it could actually be a true stimulant as well, one that is actually scheduled, one that is not over the counter, but also prescribed. There are two potential outcomes in someone who has that abrupt rise in blood pressure. We have an outcome in which the individual remains asymptomatic, and we have an outcome in which the individual demonstrates symptoms, and that I believe is Mr. Pitt. What is the single best answer? What is the syndrome what is the name of the condition that results when somebody has that abrupt rise in blood pressure without symptoms. It's called a hypertensive urgency. The hypertensive urgency with a U is a medical diagnosis made that is based on blood pressure reading alone. Patient is asymptomatic. There are no clinical findings. I believe it's the cutoff is about 210 over 120, right? Without symptoms, hypertensive urgency. And that name, that label, hypertensive urgency, is just that. It's focused on the blood pressure, which may or may not be due to the drug-to-drug interaction. So any rise in blood pressure over 210, or should I say 210 over 120, buys you that diagnosis. Similarly, or I should say conversely, there is the situation in which you have a rise in blood pressure and the patient is symptomatic. So there's some evidence of end organ failure. For instance, the brain, an individual can have a stroke. Heart could be heart attack, right? So there's kidneys, acute renal failure. So there's some evidence of end organ failure. That is called the hypertensive emergency or the hypertensive crisis. Those two terms are relatively interchangeable, right? Hypertensive emergency and hypertensive crisis. And in Mr. Pitt's case, the cause of that is the drug-to-drug interaction between two sympathomimetics, that is, two medications with that stimulant side effect. And in our case, it would be the combination of that MAOI. And that is the drug, the antidepressant drug, that on psych shelf exams is most commonly implicated when the single best answer is the hypertensive crisis or hypertensive emergency. Very often on psych shelf exams, often 60% or more, question writers do not expect psychiatry clerks to pick up the acute renal failure. Usually it's delirium, right, due to stroke. So the end organ is the brain on psych shelves, more often than not. So it'll be part of your differential diagnosis for acute mental status change, likely due to stroke, brought upon by that abrupt rise in blood pressure. So that's the evidence of that end organ damage, in this case, the end organ being the brain. An individual presents with delirium, and their delirium is deemed to be due to a medication interaction. However, in this case, while they are on the MAOI, there is no evidence that the individual ingested another sympathomimetic. What medication will you now inquire about that might explain the individual's new onset delirium? Let me re-ask the question. Similar presentation, an individual comes in with evidence of acute mental status change for which you diagnose delirium. The individual is on an MAOI, just like on our last case. Only this time, there is no evidence of an additional medication, either prescribed or over the counter, with a sympathomimetic effect. So, and you are ruling out hypertensive emergency, hypertensive crisis. But I am explaining and I am describing a situation in which there is drug-to-drug interaction. Which drug are you now going to inquire about?
I'm sorry, you're saying there is still hypertensive crisis or emergency? Or no, you're just saying that they have delirium and there's another drug that interaction is causing that. Wouldn't you want to consider like an antihistamine or like an anticholinergic, something like that could interact and cause a delirium-like picture? That's
going to be at the top of your list, right? So cumulative anticholinergic effect can bring about the anticholinergic crisis. I would ask that all learners simply search for anticholinergic toxidrome for the acronym, right? Because there are about 5 very common manifestations of that anticholinergic toxidrome. That is, the delirium that is induced by polypharmacy with cumulative anticholinergic effect. Now, you can actually overdose a person on one medication with anticholinergic side effect. Right? That is, and very commonly on shelf exam, we have someone usually elderly in the hospital who can't sleep and is provided Benadryl. And you're called because of new onset confusion. So Benadryl, anticholinergic, antihistaminic side effect, can induce delirium, single low dose. So it doesn't have to be polypharmacy, and it does not have to be a cumulative anticholinergic side effect. But the toxidrome is something that would be high in your differential diagnosis. The other medication that you have to strongly consider here is a serotonergic agent. And by adding a serotonergic agent, such as an SSRI, to a drug regimen that includes the MAOI, you could have cumulative serotonin effect. And that rise in CNS serotonin, serotonin is a neurotransmitter in the indolamine class, can also result in delirium and related symptoms. Those related symptoms are captured in a triad. So the individual presents with delirium, upper motor neuron signs, including hyperreflexia and myoclonus, and autonomic instability, right? So there's that rise and fall of blood pressure.
If you had a serotonin, if you were looking at like a picture of serotonin syndrome though, wouldn't you also be expecting them to have high blood pressure? So like, wouldn't that in that case sort of like also lead you towards hypertensive urgency?
It's true. It's more labile blood pressure and autonomic instability than an abrupt rise in blood pressure. But yes. And care and treatment of this condition is, quote unquote, supportive. So maybe a medical intensive care unit support and close monitor of blood pressure. Exactly what you said. Mm-hmm. Now, the hyperreflexia distinguishes this condition from yet another medication-induced syndrome called the neuroleptic malignant syndrome, which is a side effect of neuroleptic drugs, especially when individuals are on multiple neuroleptic drugs or antipsychotic drugs. NMS also has autonomic instability and also has delirium as two parts of its triad. But the third part is areflexia. So there'll be absent reflexes, whereas in the serotonin syndrome, the individual will have hyperreflexia. So that might be a distinguishing component. We're right at the bottom of the hour. Any final observations or questions? All right, we'll leave it there. For our interns, we'll be back with our roundtable discussion at about 9:15. We'll see everybody back then. Thank you.